I don't know. I'm gonna do this run through. I'm going to do this run through right now without my hair up, just to see if I can control myself. Just to see. Okay. Ready? Stopwatch. Okay. All right. Good morning. Good afternoon. It's 1 o'clock. Good afternoon. Good afternoon. My name is Quin Jones, and I am a fifth-year PhD candidate here at Virginia Commonwealth University. And today I'll be talking to you about dynamic mathematical approaches for understanding pain in sickle cell disease. I'm originally from Jackson, Mississippi, where I got to witness public health disparities firsthand in my family and in my community. And this is what sparked my initial passion for public health, pathology, and problem solving. As a mathematical scientist, I aim to do work that helps eliminate the health disparity gaps for illnesses that disproportionately impact Black people worldwide. So I have been incredibly honored and excited to conduct my dissertation research on pain in sickle cell disease. And I have been conducting this work under my advisor, Dr. Sickle. Today we'll be discussing the following. First, we will get into what exactly is sickle cell disease and some mathematical models that have explored the disease dynamics. And then we'll get into two ODE models, the first being a more behavioral approach, leveraging the sleep-pain relationship to predict pediatric sickle cell pain using an ODE model. And then we'll get into a more biological approach, understanding pain by looking at the temporal dynamics of adhesion and inflammation in sickle cell vaso-occlusive crises. And then we'll end with my next steps, timeline, and take time for questions. So, what is sickle cell disease? Excuse me. Excuse me, I'm so sorry. So, what is sickle cell disease? Sickle cell disease is an autosomal recessive blood disorder in which red blood cells that are normally round are mutated genetically to become sickle or crescent-shaped cells that stick together and cause occlusions inside vessels and arteries. This obstructs blood flow to organs, causing ischemic reperfusion damage, and also causes severe pain and inflammation. These symptoms cause chronic and acute complications all over the body, from pulmonary hypertension to ischemic stroke, with the chief complaint of hospitalizations as pain. The field of sickle cell research is relatively new, with research efforts starting only in 1949, despite its discovery in 1910. There have been some advancements in the last 2 decades with the recognition from government, with the institution of worldwide sickle cell, with the institution of Sickle Cell Day, and the implementation of genetic screening for the disease at birth, along with the availability of mobile health and technology allowing for more biological understanding of the disease. So mathematical modeling has recently been used in addition to these to understand sickle cell, to aid in sickle cell research. We can see here government funding for disease research in 2022, and we can see that compared to other diseases that are also, here we have the government funding for diseases in 2022, where we can see sickle cell funding in comparison to other blood disorders, other inflammatory diseases, and other diseases that also impact the same demographic. And we can see at the bottom of each chart that sickle cell is the least funded, potentially connecting to the lack of sickle cell research progress in the last 100 years. One might surmise that the lack of resources for this disease and others is the anti-Blackness that permeates all corners of society, but most specifically the fields of public health and medicine. But most specifically the fields of public health and medicine. Because the disease demographic is majority Black and brown patients, one might surmise that companies, hospitals, and institutions create treatments and systemically price out minorities if any treatments are created at all. So we really would like to take advantage of the aid of mathematical modeling to find more solutions and understand the dynamics of sickle cell with minimal cost or injury to patients. because the CDC estimates that approximately every 1 in 365 Black Americans is born with sickle cell disease, and there are also many living with sickle cell disease abroad. And this is a disease that is characterized by unanticipated pain episodes that last from hours to days to weeks, that starts at birth in childhood and turns into a chronic disease in adulthood. So there are many Black people worldwide living in severe unanticipated pain. And much has been done recently thanks to and there has been some progress recently due to math modeling to investigate the sickle cell disease dynamics further, and we have done a literature review of said models. So I feel like I want to transition that better. And a lot of pain. So sickle cell research has So many techniques have been employed to understand sickle cell disease dynamics, and mathematical models have recently been implemented thanks to the advancements in technology. And we have done a literature review of said models. Sickle cell disease is a complex disease, meaning that it can be studied from multiple scales. It can be modeled from the molecular scale, looking at genetic inheritance or genetic frequency. It can be modeled at the cellular level, looking at cellular dynamics, looking at red blood cell behavior or interactions. It can be looked at the organ system level, looking at the impact of vaso-occlusive crises on ischemia reperfusion and on other organ system damage, as well as through population epidemiology and treatment efficacy studies. So there are many scales at which one can study sickle cell disease, meaning that there are also many mathematical modeling techniques that can be applied depending on the project. We have seen statistics and machine learning models be useful for their predictive power, along with their ability to unravel variable relationships through regression and modeling. We have seen discrete dynamic models be used for a similar reason for unraveling those relationships. And then we've also seen the implementation of ODE models and PDE models to understand the disease dynamics over time at these multiple scales in either solo or hybrid models. These are the primary research areas as discussed before in sickle cell, and today we will primarily be talking about the first two, being pain behavior and management and the dynamics of the vaso-occlusion crisis. And because there are so many techniques that we've seen in the literature for choosing a way forward, there are four primary factors to consider when creating a math model for sickle cell, or for choosing a math modeling type, and that is dependent upon the subject or research aim and the available data for that aim, the time points at which that data was taken, and what is or is not known about the system. These things will likely determine the kind of model that is chosen. And for both of our models, we have chosen an ODE approach. The first being a more behavioral approach, looking at sleep and pain, and the second being a more biological approach, looking at the pathophysiology of sickle cell disease. So the first model we will discuss is the sleep pain model for sickle cell disease. The first model we'll discuss is an ODE model leveraging the sleep pain relationship in sickle cell disease to predict pediatric pain. This project began when we met with psychologist Dr. Rowry, who has been doing sickle cell research for pediatric patients for some time. She had already conducted a 2019 survey of a pediatric population where they did diary entries submitting their medication usage, pain level, and a host of other health variables. From this survey, from these results, statistical analysis of the diary entries revealed that there was a high correlation between low quality sleep or a drop in sleep and high pain severity the next day. And because we know that poor sleep is often comorbid with pain in chronically ill populations, she was wondering if we could use a dynamical systems approach to take advantage of this evident relationship and predict sickle cell patient pain and investigate this relationship further. So we decided to create a dynamical systems approach for understanding this relationship, and the primary aim of this model is to create a model predictive enough for future health app integration for prophylactic pain management. So the data that we used was from this study where there were 88 youth aged 8 to 17 years old, so children and adolescents, and they completed twice daily diary entries for 4 to 8 weeks where they tracked their pain on a scale of from 0 to 100, where they tracked their medication, where they tracked their pain from 0 to 100, and other health variables. Where they tracked their pain from 0 to 100, their sleep from 0 to 100, along with other health variables, along with their pain medication, along with their medication usage. Some users were on hydroxyurea, a standard sickle cell treatment for reducing sickling, and many others were also for reducing sickling, and majority were also on either opioids or other analgesics for pain management. Those opioids were classified as either long-acting, short-acting, or non-opioid medications. And we use this information to input into our model. We first decided to understand the relationship between sleep and pain visually. So we plotted the raw patient data against their sleep quality, and we can see here that even with two different pain profiles, the left one having pain episodes that reach to about 80 or 90 and are quite frequent, versus the patient on the right who doesn't have pain episodes quite as high or as frequent, we can see a drop in sleep quality with a rise in pain severity the next day on both profiles despite the different pain presentations. So with confirmation of this relationship, along with the essentials from the data, we were able to create our mathematical framework. So we processed the data down to the pain severity, the normalized sleep quality with bad sleep times identified, and the pain medication usage. And we input this data into our mechanistic model where the Effman-Khan optimization algorithm where the Effman-Khan least squares error optimization algorithm calculates patient-specific parameters for their natural pain relaxation rate, for their drug relaxation rate in the presence of drugs, and their individual pain sleep correlation coefficient. And these are used to help create P, the model output. I think I want to say that a different order. Hold on. I gotta sneeze. Okay. So we input these data into the mechanistic model where we are outputting pain level P, and we are inputting the drug and sleep quality as factors into pain level P. And then the MATLAB Effman-Khan optimization algorithm that uses least squares error estimation to and then and to predict pain level P with sleep quality and medication information as factors for pain. And then the MATLAB Effman-Khan optimization algorithm using the least squares error estimation calculates personalized patient parameters where they each have their own individual pain relaxation rate without drugs, their drug relaxation rate, and their own sleep pain correlation. We then output the simulated pain profile against the raw patient data, and we measure model accuracy by and we assign predictive value based on measures of accuracy such as sensitivity and specificity. So here we have the pain equation, which essentially says that pain level P over time drops at a cumulative and constant rate of K0 plus Ki when drugs Di are present, and pain increases at a rate beta-0 when a patient experiences a night of bad sleep with an epsilon of the sleep event. This means that the primary reduction of pain comes from medication, and the primary driver of pain in our dynamic is the sleep coefficient. Each of those DIs represents a long-acting, short-acting, or non-opioid medication where they each have their own DI equation representing the concentration of that drug in the body. Here we assume the drugs eliminate at a constant metabolized rate, KDI. and therefore this makes up our full ODE model system of 4 equations measuring pain level over time and medication levels over time, with the medication levels feeding into the final pain level. Here we have one of the original simulated pain profiles with, you can look at the bottom of the chart here, the red line being the pain simulation and the dotted black line being the patient reported pain. We can see here that while the shape is the same, it is delayed and not quite accurate, therefore letting us know that our model is capturing some dynamics, but perhaps the formulation or data is not quite effective. So this led us to wonder, is sleep enough of a predictor to anticipate pain episodes through this dynamical systems approach? In what way can we take advantage of the data we do have to better understand this sleep-pain relationship? We know from Yang et al. 2018-2019, where they created a machine learning algorithm for predicting pain, that patient cohort plays a vital role in the relationship between pain and the physiological symptoms. So we decided to really understand and address our initial assumptions about this population by doing a parameter sweep to find ideal thresholds for our model prediction. So we began with 3 initial assumptions. The first being that we saw from the visualization that there is a drop in sleep quality in our assumptions, meaning that we can count that as a night of bad sleep. So that means we must quantify, though, what exactly is bad sleep for this population. Is it any night of sleep under quality 80, under quality 70, under quality 60? Where is the line that marks bad sleep? And then we also know that from the literature that sleep debt and sleep deprivation can have a delayed and cumulative impact on pain symptoms. So we assume that just one night of sleep information is not going to be predictive enough for pain, and instead approach it from a cumulative effect, meaning that we assume that maybe 2 days or 3 days or 4 days worth of sleep quality information will be more predictive than just one day. We implement this by a moving mean average and conduct that at each window. But which window is accurate? 2 days worth, 3 days worth, which is more predictive? And then we also decided to see, and then we also saw from that initial pain profile, from that initial transient, that matching pain level exactly over time can be quite difficult since it's so subjective and variable without more physiological time series data, and decided to switch to a more pain onset approach of understanding pain in this context, meaning a more on-off category based fitting. Can we match the switch from on and off, or high to low pain, or from low to high pain, and where exactly should we place that switch from low to high pain that will be most predictive? Does the switch start at 10? Does it start at 30? Does it start at 50? Where can we mark the switch from no pain to pain onset? So in order to address these assumptions, we have to do a parameter sweep. We wanted to address these assumptions because by setting these thresholds, it really determines where certain days are, which days are counted in the model, and how that predicts the pain output. We are assessing model performance based on measures of predictive accuracy such as sensitivity, specificity, and accuracy. We are primarily interested in sensitivity because that is a true positive fraction, and we are interested in prophylactic pain management and want to know when patients are in pain. And that I had a bathroom break. Okay. Okay. And we also hope this informs future data collection for sickle cell clinical research experimentation in the future. From this model, we see that there is still a need for a more biological understanding of the pain mechanisms in sickle cell disease. And it is known that the primary cause of pain in sickle cell disease is the vaso-occlusive crisis. So we have created an ODE model of the temporal dynamics in VOC of inflammation and adhesion. So biologically, the vaso-occlusive crisis is when those no longer round but sickle-shaped cells stick together and cause obstructions in the vessel or artery environment, and that obstructs blood flow, causing ischemic reperfusion damage, causing oxidative stress and inflammation in the body, which often re-triggers the vaso-occlusive crisis. Why can't I figure out what I said here? Exacerbating the pain symptoms that gives recurrence and reduce oxygen. Okay. Biologically, the vaso-occlusive crisis is the obstruction of blood vessels from the sickle-shaped red blood cells. They stick together and cause obstructions that cut off the blood supply to various organs, causing ischemic reperfusion damage. This damage and reduced oxygen often exacerbates pain symptoms and VOC occurrence. We know that the sickle cell crisis the sickle cell crisis has most recently been thought of as a chronic inflammatory disease, since it can be thought of as the interactions between the blood cells, immune cells, and nerve cells that interact in the body. There is a lot known about these components biologically, yet in Zhang et al. 2021, yet it is not known. A lot is known about these components. A lot is known about these mechanisms biologically, but the pathways which are most significant and treatable are still unknown. We see in Zhang et al. 2021 that much is known about these interactions biologically, yet little is known about which of these pathways is most significant and treatable for pain and sickle cell disease. And dynamic math modeling allows us to understand this process better at minimal cost to the patient and with minimal cost and injury to patients. So we aim to use this new understanding of the inflammatory processes in sickle cell disease to predict the likelihood of secondary VOC as defined by Zhang et al. 2021, and elucidate potential inflammatory pathways for understanding and alleviating pain in sickle cell. So in Zhang et al. 2021, they discussed the 4 phases of the vaso-occlusive process in regards to pain. How the first phase is low aching pain, the second phase is max aching pain, and then the third phase is often constant max pain, and this is often thought to be from the build-up response from the inflammatory process. So then there is usually an assumption that this has spontaneous resolution and it goes to phase 4 of no damage or healing and end of the visit. But what is more likely to happen is explained in Zhang et al. 2021, that there is a prolonged episode of VOC due to the inflammation cycle response, which they dub SVOC, and this means the process starts all over, the VOC occurrence is exacerbated and triggers new inflammation, new pain. And we have created an ODE model that models this process from phases 1 to SVOC, and we would like to predict the likelihood to SVOC and elucidate which pathways primarily impact that likelihood and how to reduce that likelihood to decrease hospital stay and pain episode duration. So our primary research questions are: can we use this model to represent the steroid inflammation we know is evident in sickle cell patients? We know that they have higher levels of platelets and neutrophils due to that chronic ischemic reperfusion damage and vessel wall pain and vessel wall damage. So can we accurately represent that in patients? And then which parameters are most significant to reduce SVOC likelihood? We are using this likelihood measurement as an understanding of the progression from a steady state in phases 1 and 2 to a state of crisis and a stage in VOC phase 4 and SVOC. And VOC's phase 3/SVOC. So can we determine which pathways significantly impact this transition from steady state to crisis, and which parameters are most significant? And then we're most interested in which treatment options which treatment options most effectively reduce this likelihood of SVOC, secondary vaso-occlusive crisis, and returns us to the resolution state instead of a recurring loop of pain and inflammation? So to understand the temporal dynamics, we are looking at the interactions in VOC. When looking at the inflammatory biology of sickle cell, we are looking at the interactions between red blood cells, round and sickle-shaped cells, and their interactions with the endothelial wall and cells. And these each have their own adhesion molecules that they bring to the environment, along with a reaction from the body that involves the cells, platelets, neutrophils, and macrophages. So in the sickle cell vaso-occlusive crisis, we know, so in sickle cell disease, red blood cells that are round are mutated to become sickle-shaped cells, so that are more adhesive and likely to so in sickle cell disease, round blood cells are mutated to become sickle-shaped cells. These sickle-shaped cells are more adhesive with adhesion molecules expressed on the surface because of this mutation, and they also die relatively quickly. Round blood cells die every 100 to 120 days versus sickle cells dying every 10 to 20 days, meaning that there is a constant shortage of red blood cells from this quick lifespan known as anemia and sickle cell anemia, and the adhesion of the and the polymerization of sickle cells causes this more adhesive state of the blood cells that causes inflammation in the body. The constant hemolysis and adhesion of the sickle cells causes the endothelial cells to activate, meaning that they express adhesion molecules on the surface and are more easily sticking to the sickle cells in the environment. And the adhesion of these sickle cells to the endothelium then triggers the coagulation cascade, an inflammatory or an immune response in which platelets, neutrophils, and macrophages are recruited to the site of damage to solve the problem. This solution, however, is often the cause of more occlusions in sickle cell patients, since platelets, neutrophils, sickle cells, and endothelial cells all have adhesion molecules now in the site and are each causing complex aggregates, meaning they're all sticking together, causing clumps and causing obstructions, even though this was a solution response from the body, causing a sterile inflammatory state from this constant triggering of activated endothelial cells. So in sickle cell disease, we see that while there should be resolution, the coagulation cascade and immune response actually exacerbates the VOC cycle and pain presentation. This lets us know that inhibition or interruption of any cell population or type could lead to a reduction in pain symptoms or duration. So we, from this, have been able to create our model schematic where we are tracking the concentration of these cell types in one area over time and measuring how those concentration of these cells impact the likelihood of SVOC. So here, this model is an ODE model, and it is based on the Torres et al. 2019 model, where it uses a Michaelis-Menten growth type model for the population size, and it tracks these cell dynamics individually, like I said, as a concentration over time in one area. So when looking at the equations, we have the first stage, which is the hemolysis of SRBCs and the resulting inflammation or activation of endothelial cells. So we have here AS, the amount of heme or dead sickle cells, is if the concentration of heme in one area over time is equal to the amount of dead RBCs, or the increases at the rate at which SRBCs die, and they decrease at the rate when they are removed by neutrophils and macrophages. And then we have the equation for the activated endothelial cells. They are activated from this hemolysis and from neutrophils and from macrophages. So the amount of activated endothelial cells increases by the activation from net heme and macrophages, and reduces when these activated cells have been inflamed for too long and then turn into damaged cells that die off to later become progenitor cells. From this inflammation of the endothelial cells, we have the coagulation cascade. This starts with the influx of platelets and neutrophils to the site to help reduce damage. So platelets, the concentration of platelets in one area over time is equal to the rate at which platelets in one area increases is by the activation from heme and from those activated endothelial cells, and platelets reduce at a rate mu p. And then neutrophils are also brought to the scene with its two subtypes. So neutrophils are increased at a rate by which they're activated from heme and platelets, and they decrease at the rate in which they switch to nets or neutrophil extracellular traps that have extra glands, extra arms that make it more adhesive and more pro-inflammatory, and they also decay at a rate mu n. When they decay at a rate mu n, they become apoptotic neutrophils that release signals that get them removed by macrophages and neutrophils, and then also that later then die off in secondary necrosis. And then we have the concentration of neutrophil traps in one area over time, which is equal to the amount of neutrophils that are transitioned from regular to and then the amount of neutrophil traps in one area over time is equal to the amount that is switched from neutrophils due to the level of heme in the body, and they decay also at a rate mu n. Also, part of the coagulation cascade is the influx of macrophages to the site following the neutrophils. So these are brought to the site to help reduce inflammation, to eat some of those apoptotic neutrophils and the heme and those toxic things in the environment. So the pro-inflammatory macrophage, the anti-inflammatory macrophage M2 concentration in one area over time, it increases when they are activated by the neutrophils, the apoptotic neutrophils, its own cytokines, and the byproducts of those activated endothelial cells. These all recruit macrophages to the site, and these macrophages M2 are actually often switched to M1 in sickle cell disease. It has been shown that the levels of hemolysis in sickle cell patients often changes the phenotype expression of M2s into M1s. So the concentration of M2s decreases, at which the rate they are switched because of this heme, and at the rate they are switched because of the apoptotic neutrophils, and then they decay at a rate mu m. Therefore, the concentration of pro-inflammatory macrophages in the environment, M1, increases at a rate that they are activated by their own cytokines, M2 cytokines, and those neutrophils, and they also increase by the rate at which those M2s are transitioned into M1s through the heme levels in the body and through the apoptotic neutrophil interactions, and they also decay at a rate mu m. So in the coagulation cascade and this inflammatory state, what we have is the result of an increased presence of adhesion molecules in the environment and new endothelial damage in the patient. So the amount of adhesion molecules now present, so now the concentration of adhesion molecules in one area over time is equal to the amount that sickle cells, platelets, neutrophils, and endothelial cells release into the surface, expressing them, and decreases at a rate mu am. And the amount of damaged endothelial cells and the amount of damage and the concentration of damaged endothelial cells in one area over time is equal to the amount increases when the activated endothelial cells have been inflamed for too long and become damaged, and these cells decrease when they die off and become progenitor cells that later mature into activated healthy cells, that mature into healthy endothelial cells. From these cell concentrations, we have a resulting environment of the temporal dynamics in sickle cell, and we can use these dynamics to understand the SVOC likelihood as described by Jang et al. 2021. So in determining SVOC, we first have a few model assumptions. We assume that there is a steady state influx of red blood cells and sickle cells, so those are set at a value and assumed to be constant. And we also have an assumption of 3 parameter states or 3 patient states, where there's a healthy patient state, sickle cell steady state and sickle cell crisis state, where the steady state is often here associated with phases 1 and 2 of that low or aching pain, and the crisis state is known as that max pain SVOC increased state. So here we determine, and then from those crisis, and then from those states, there are different parameter sets for those corresponding states. And we determine the likelihood of SVOC based on the concentration of all of the primary cells in that area. So if the adhesion molecules, neutrophils, platelets, and activated endothelial cells are all above a certain amount, as the amount of those cells increase in that area, then the likelihood of SVOC will increase. We have set the values for SVOC likelihood from 0 to 1. These value distinctions are arbitrary but have been placed on the scale to represent the progression from one stage to another. So when there is no damage, SVOC likelihood is 0. And then as the population of these cell types increases, the damage likelihood increases, with it going from 0 to 0.2, 0.5, and 0.8. And this is representative of the likelihood of this VOC cycle starting again and us running the model again to show more pain. So